Everybody, even though we're not sure who you all are, thank you very much for letting us just show you a few of these bits of data. This is actually a very small piece of the whole jigsaw, which was a study we did on the children who received autologous stem cell transplant at Great Ormond Street. So they're a subset of the patients you're going to hear either from Nico or Paul from the UK cohort. And these 5, we saved blood prior to their stem cell transplant and again down the line some months and years after transplant. And so on the second slide is just a sort of cartoon to explain some of the data I'm going to show. And it just shows that what we've done is some sequencing of a particular molecule from their T cells called the T cell receptor, which allows us to assess how much of the cells that come back after autologous stem cell transplant are new, have been made new, fresh, straight out of the thymus, and how many of them might be old. Okay, I'll add her in a minute. Could you just email Juliana to tell her I'll add her in a minute, Paul?
Okay.
And so that we can sort of begin to assess what really happens, at least in the T cell compartment, to the kind of immune system after you've put back new stem cells. Do you grow a completely new immune system like you were a newborn baby or not? And so on the third slide is the first bit of data. And basically you don't need to know great detail of how this method is done. It's kind of a sequencing method really of a particular molecule from T cells. And where there are lots of spikes making a kind of circle, so obviously you can't see my pointer, but in the upper row, can people see where it says before stem cell transplant? Can you see that, Nico?
Yeah.
Yeah. So in that upper row are all from one child, a whole load of different types of T cell assessed for their diversity. And the more whole the kind of distribution is, the better, really, because the immune system is diverse and has lots of different T cells which you need for your immune system to be healthy. And 1 month after transplant, you can see that she's got very few spikes on the graph, and that's because she's got very few T cells, and some of them have come back very quickly. And so 1 month after transplant, she's not yet got a normal immune system, if you like. But what we noticed is that on slide 4 now, in quite a few of these children, actually 3 out of the 5, the immune system reconstituted pretty well. And you can see that at the bottom of the slide for slide 4, where it says 12 months after stem cell transplant. You can see it's come back to quite a good diversity. But what was really interesting, and that's on the 5th slide, is that some of them actually maintain this very restricted cell repertoire for a long time. So it means that even when the doctor in clinic measures their T cells and says, great, your T cells are back to normal, actually within the number of T cells that that child has, you still have rather a limited repertoire. I should say that 4 out of these 5 cases, I've got the list of cases at the end, and probably Nico may have already shown you the 8. 4 out of 5 made a really very good response to their transplant, and their systemic features and arthritis pretty much went away or was much easier to transplant. But then the key point was that on slide 6, what we did was take these pieces of DNA from T cells and sequence them out. And what we found is that very frequently, in most of these children, some of the cells that they have back a year later were actually there at the beginning. And the distribution of whether the cells were from before or after transplant tended to be about 50-50 in some of these families. And that's just shown in slide 6 down at the bottom. This is a whole year later. This particular family for CD8 cells is still very restricted. This child was completely well by then. This is probably a T cell that's nothing to do with systemic JIA. It's probably one that's quite good because we worked out it was within a memory clone, and it's probably a way to stay immune to infections. And so on slide 7, you just see a summary of that. And this just says, okay, in these children, in this particular family, say, prior to transplant, these were some of the clones. This is the size out of the total number that we sequenced up. And you can see that the white bar and the blue bar, for example, and the red bar are all there before transplant, and some of them are there again after transplant. So I guess just to move quickly to slide 9, this also shows just the counting of these cells. So here you see counted by whether they were memory or naive, number of, in this case, CD8, but it's really the same for CD4, number of memory cells acutely after transplant. So what that tells you is some of the cells survive, whatever you do, whatever drugs you give, and some of these kids also had irradiation. Some of the T cells within the body survive that. That's probably a good thing, because they grow up quickly and they reconstitute. And then by about 2 to 3 years, we're back to normal, both numbers and ratios. So that just tells us something really important. And I don't know, Nico, did you show the Treg data?
Very briefly. Yeah.
Very briefly. But what it tells us, and now I'm on to slide 10 and I'll stop going on about TCR sequences. What it tells us, I think, at least in these 5 kids, and assuming they're similar to others, that after you have had an autologous, so your own stem cells come back, some of those stem cells do make new T cells, and obviously B cells and monocytes and all sorts of other things. But what you then have is like a mixture between your old immune system and your new immune system. So it's not true to say that this treatment works by giving you a completely new immune system. That's actually not the case. At least in the T cell compartment, you're probably about 50-50 old-new. And of course, the old cells, we're calling them old, they're not really old, these children were very young, but the memory cells which survive when you have your transplant and you think you've moved or removed all the T cells, those memory cells, they divide very quickly. So they're kind of better at surviving just after the transplant. But despite that, despite the fact that these children had a mixture of old and new, actually 4 out of 5 of them, which is just probably on slide 11, 4 out of 5 of those children got a complete remission. Now, one case, who may well have been in the series that Nico already showed you, relapsed extremely quickly. She basically never made a response to the transplant and subsequently had a very stormy time and, in fact, subsequently died after this, probably after the report that this is written for. But I don't think that's necessarily to do with the exact number of T-cell clones pre or post. I think there are probably other reasons why we lose some children after this procedure. So that's really all I wanted to say. Sorry if it's a bit technical, and I'm really happy to take questions, even though I can't see you guys.
Okay, Lucy, thank you very much. I think
Does that make sense?
Sorry?
Did that make any sense?
Yes, it fits very well with my introduction, I think. Maybe if there is 1 or 2 short questions for Dr. Wadderburn's topic. Otherwise, we continue with Dr. Paul Vase with the allogeneic approach. And then after...
I just have a really
Betsy.
Question. Hi, Lucy, it's Betsy.
Hi, Betsy.
I just wondered whether you know anything about the degree of cross-reactivity of the surviving.
Yeah. We knew about just one patient where we had enough blood, and actually the surviving big clones were largely CD8, and we showed at least by tetramer that some of them were CMV and EBV positive, which is why, reactive, which is why I kind of hinted I think it might be a good thing that memory cells grow back, because some of them will have very important immunity to offer. Whether they are cross-reactive with self-antigens, fantastic question. Don't know the answer.
Well, I actually even meant cross-reactive with pathogens. So did you get any double tetramer stains?
Would we have known that? I don't know if we know the answer to that, because when you're so limited with cells, we may have had them in the same panel. I can look back, but it may not answer your question, because obviously we use well-characterized EBV, CMV peptides where we know where the HLA fits the reagent. So I'm not sure that will exactly answer what you're really asking. But can I ask you a question back then? Obviously all TCR can be cross-reactive, right? Probably on many peptide MHC combinations, but would that give them a survival advantage?
I don't know, but I think that the question is one of to do with what are those cells. I think it might give them a survival advantage in terms of the likelihood that they will see some determinant, like CMV determinant, but also an EBV determinant, and also other determinants that would lead to their homeostatic proliferation and survival.
Yeah.
Okay.
Yeah.
Yeah.
I totally see your point. Yeah.
There's another question, John.
Yeah. Can you just drill down a little bit on the patient that died? You sort of mentioned that you didn't think it was necessarily because of the stem cell treatment and the T-cell variation, but what do you think happened? Like, what's your hypothesis?
So Paul may wish to comment. You remember this child, Paul, I'm sure, because they moved to London. Do you remember the child? Yeah.
You might have to remind me a bit more. It was 3 or 4 months after the autograft?
Yes. Well, the initial relapse was pretty quick, 5 or 6 weeks even, correct. And we later did an allo, but she died following that.
I know her very well. So actually, the death was very sad and very unexplained. Actually, it was after an orthopedic procedure. So she was well, free of disease, and she had an orthopedic procedure on one of her knees and appeared to have died of sepsis afterwards.
But I think the point was that she relapsed from her autologous. You then kindly did an allo.
Yeah.
She did get some GVHD, but maybe you're going to talk about that later.
It's a brief mention, but she was clinically disease-free.
If you look at slide 11, sorry, Paul, that you may not have these, she's patient 3 on that table. And I don't know, Paul, you might like to comment, but she got ATG at the lower dose, a cyclo, which they all got, and I've just forgotten the P, but she didn't get any irradiation or fludarabine. So I personally wondered if the degree of remission very early, remember, 5 or 6 weeks, they haven't got their cells back. So it's whatever you've done, if the disease comes back, is it that you actually haven't controlled the disease first? I think the important thing, I'm sure, Nico, you said this, is that my belief is that the huge amount of treatment just prior to transplant is the initial disease controlling step. And then you give back stem cells. The stem cells themselves obviously don't wipe out the systemic disease. They just grow back an immune system. So in her, I felt we'd actually not controlled her disease quite as fully as the others. Is that fair, Paul?
Possibly, yes. I mean, we don't know. We don't know what the cause of early relapse is. Very difficult to be precise.
And why did she get only cyclophosphamide, Paul?
ATG and ATG.
Yeah, ATG, yeah.
It was a phase.
That was the protocol at that time. Some years ago.
And then you have actually stepped up since then, Nico, right?
Say again.
I mean, you wouldn't do only ATG and cyclo anymore if you were conditioning for this procedure.
Yeah, that's true. Fludarabine, yeah.
Long time ago.